So I'm going to talk to you about biochemical recurrence. So you get treated for prostate cancer, and then you get an elevated PSA. And at the time, you need to do the same thing you did when you were first diagnosed. That means don't rush, get educated. And a lot of the things I'm going to talk to you about today are kind of new. It's kind of my viewpoint on things based on some emerging data. Biochemical recurrence refers to a detectable PSA after... I got it, okay. So biochemical failure means that you've been treated with surgery and you have a detectable PSA, or you've been treated with radiation and your PSA has reached a certain endpoint. And the standard definitions for surgery are a PSA of 0.2, and for radiation, the most common definition, which is actually evolving, is so-called Phoenix definition, which is so-called nadir, your lowest PSA after radiation, plus 2. Now, it's important to understand that these are not equivalent endpoints. So the Phoenix definition was devised to predict important clinical events like metastases, survival, but the surgery definition doesn't predict events like that. So there are two different definitions. Now, Stephen and I talk about this all the time. Should the Phoenix definition be reconsidered? And I think you're seeing now that it is being reconsidered because many of those treated with radiation below the cut point may have a PSMA PET avid lesion. Detecting recurrence at lower PSA levels after radiation, you have more organ-confined disease. The patterns of actually recurrence, I'll show you, are pretty similar after radiation and surgery, although they may vary by treatment type. Again, I think I showed you this here. You don't need to look at this just as evolving many definitions for biochemical recurrence after radiation. And I'm seeing this happen now. Stephen, I don't know if you're seeing it, but I saw a patient from the East Coast where they said a detectable PSA or a concerning PSA after radiation was 1. And if you look at the literature, what's happening is they're starting to lower this PSA cut point after radiation to detect recurrence a bit earlier, local recurrence, where it may be more treatable. I think one question is asked is, I had a high-risk cancer, that means a high-grade, high-volume cancer. I was treated with surgery. My PSA is undetectable. Or I had radiation, and after radiation, with or without hormonal therapy, my PSA is very low and stable. Do I need additional treatment? So a lot of men ask me, well, I had a high-risk cancer. My PSA is undetectable using these hypersensitive assays. And the answer is, we don't think you need additional treatment. We look at this space all the time, and our most recent analysis suggests that if you have a low PSA afterwards, you don't need additional treatment without either reaching the PSA cut point or having disease. The big questions now when you have biochemical recurrence is, how to evaluate and when to manage. And this space has significantly evolved over this last, I would say, 5 years, because increased use of contemporary imaging, Spencer will talk about this, PSMA PET, and more knowledge about recurrence patterns. Like an initial diagnosis, at the time of recurrence, one should take a measured approach to best identify an optimal path for treatment, or in some cases, surveillance. I'll go over that as well. So what is needed? Just like at the time of diagnosis, you want to know the grade of the cancer, this grade group 2, 3, 4, 5, stage, was it confined to the prostate, beyond the prostate? What's your PSA at the time of treatment? That gives you a good idea what your risk of recurrence is. Again, a higher grade, higher volume cancers got a higher chance of recurring in an adverse way compared to someone who had a lower grade cancer, organ confined. How were you treated? Surgery versus radiation, hormonal therapy. The PSA after treatment. Now, I do want to point out that after radiation sometimes, your PSA will go down and then bounce a little bit. And this usually occurs, Stephen, in my experience, have been around 12 to 18 months. So again, if your PSA takes a bounce afterwards, after radiation, don't launch it at anything, just wait a bit and repeat the PSA. Time to failure. So again, how many years elapsed between your treatment and when your biochemical recurrence occurred? And something called PSA kinetics. That means the rate of rise of PSA. Now, one important thing, when you're using hypersensitive assays, you overestimate the rapidity of doubling. So again, if you're looking at going from a PSA of 0.13 to 0.17, again, because it's a low number, you tend to two-thirds of the time you overestimate the rapidity of the PSA kinetics. So usually what you see, most often what we see is the PSA will go up and start to flatten in about two-thirds of patients. Not all, but about two-thirds. So a high-risk patient would be a high-grade, advanced cancer time of diagnosis, early recurrence, and I'll show you some data from UCSF, and a rapid PSA doubling time. A low risk would be a lower risk patient, a long time between surgery and relapse or radiation relapse, and a slow rise in PSA. So these are two completely outcomes in these patient populations. Now, we used to treat them uniformly, and we, in the past, 10 to 12, 15 or 20 years ago, men who reached a cut point of 0.2 always got radiation. It turned out that, at least in the past, that men who failed by radiation always got hormonal therapy. That's changed right now because we do know, and Stephen will go over this, there are other salvage opportunities rather than salvage ADT. Now, this is UCSF. These are at UCSF, we keep track of all our patients, and these are patients of ours that we've treated with surgery, and they developed a biochemical recurrence. Either they got treatment or they got a cut point of 0.2. So if you look at patients who had immediate PSA, that means they had surgery and their PSA was detectable, those patients, 81% get treated. So again, if you have surgery, your PSA is detectable out of the gate, you confirm that, those patients generally get treatment. Metastases-free survival, this is at 7 years, we're following this out to 10 to 15 years, was good, 79%. Prostate cancer mortality, about 6%. That means we treated them, but usually we were able to treat them effectively with radiation, hormonal therapy, or targeted radiation. If you take a patient who's had surgery, again, this is all good UCSF data, that if you have a patient who's had surgery and PSA is undetectable, becomes detectable, their outcomes are a lot different. About half of them we don't treat. That means we keep looking for where the treatment, where the cancers recurred. That means they have these slow rises. And sometimes I've had patients who had 15 years who have PSA doubling times over 3 or 4 years. So not everyone needs immediate treatment. Prostate cancer mortality is 3%. This is 7 years. We'll look at 10 years. All-cause mortality, 6%. So again, I'm just showing you that these are two completely different populations of patients. And again, if you have a biochemical recurrence, you wait and analyze all the predictive features. Now, where does cancer come back? Spencer will talk to you about this. UCSF has been a leader. In fact, UCSF, UCLA were the ones that got PSMA PET approved. I saw my first PSMA PET scans in Australia probably 15 years ago, Spencer, something like that. And I said we had to get this at UCSF. So working with Tom Hope and Spencer here at UCSF and colleagues at UCLA, we got gallium PSA PET approved by the FDA, and it's been a game changer. It's been a game changer about how we understand prostate cancer and how we treat it. So Spencer, you can correct this, but I took not only our results, which look very similar to this, but this is from a meta-analysis. And if you take men who've had surgery, most of this data is on surgery, but if you take men who've had surgery, have a detectable PSA, get PSMA PET scan, about 22%, and I think Spencer for our data is very similar to this, about 22% we can see cancer locally. Now here at UCSF, we not only depend on PSMA PET for analysis, we usually get an MRI or an ultrasound to look for local recurrence. The most common site of recurrence is in the pelvic lymph nodes. So these are regional lymph nodes. We see lymph nodes in the retroperitoneum and another 14%. Only about 16 to 20% of patients have actually advanced disease. So most patients, PSMA PET, after failed treatment, have sites of disease. You know, we used to think that prostate cancer was either localized or distant, that there was no intermediate step. That's not true anymore. We see these islands of disease in the absence of widespread metastases. So I'll show you my assessment on this. So again, I look at a patient, the initial treatment, I record the risk of recurrence, again, what kind of cancer do they have, high grade, high volume. I look at the time to recurrence. Again, if you have an elevated PSA after treatment, you always want to confirm it, so I confirm it. Time to recurrence, PSA kinetics, I watch it a little bit to get an idea about the rate of rise. And remember that This is all evaluating that will occur. Again, we use hypersensitive PSAs here at UCSF, so we go down to 0.015, not 0.2. The lead time, if you compare a hypersensitive test to standard cut point of 0.2, it's about 18 to 24 months. That means we can detect recurrences about 18 months before you would detect it by using a higher cut point. And again, I do think, and Stephen will comment on this, but I do think the cut points for radiation are being lowered, and I saw, Stephen, in the NCCN guidelines, they have actually a footnote suggesting that we'll probably lower them a bit. So if I see the patients below the cut point, that means I'm starting to detect a PSA, you get 0.13, 0.14, using sensitive assays. I usually watch them a bit to get an idea about kinetics a little bit. Because if the goal, I would like to identify the site of disease if at all possible. So I think if I could identify the site of disease, I think we can, and there's pretty good data suggests that you will alter your radiation plans depending on a positive PSMA PET or not. Above the cut point, I usually image. So that means if you reach the cut point, again, I really want to find the site of disease, because this is when PSMA PET becomes a little bit more sensitive at around 0.2 or so. So then I usually will image, again, PSMA PET, MRI, ultrasound. No disease, either I'll treat or I'll watch. I have a conversation with Stephen and radiation oncology about this. In my opinion, I think delivering radiation of a 0.2 or 0.3, and maybe even a little bit higher than that, is fine. Our most recent data suggests that the response rates for salvage radiations are similar whether you deliver at 0.1, 0.2, or 0.3, and maybe a little bit higher. If I find the site of disease, I will treat or watch. Now, why do I say treat or watch? Look, I've seen patients who've had radiation. We go ahead, they've reached the cut point, we biopsy them, and they have low-grade disease. I don't think they need to be treated. I think that I put them on surveillance. So again, not all recurrences need definitive therapy, and I've had patients who've recurred, and generally there's been people who've had radiation. I'm finding low-grade disease, and I'll watch them. So again, extent of disease, time to recurrence, PSA kinetics, and identify the site of disease, overall health of the patient. Does PSA at time of treatment affect outcomes? I'm not sure about this. So Stephen and I talk about this endlessly, but I think we're relatively comfortable that delivering treatment at a cut point when PSMA PET may be reasonable is okay, because you're balancing the ability to detect the disease and deliver more focused treatment without compromising the ability to be cured. Salvage radiation does have a risk of failure, and it has side effects. And Steve and I are working on figuring out doses to limit the risk of side effects. The patients who have the worst quality of life after treatment are generally those who've had radiation, have surgery and radiation. So again, if we give it, we want to try and give it with a low risk of side effects, fiducial markers and other things. And improved outcomes if the site of recurrence can be identified by imaging. And one thing I get asked all the time is, what about PSA cut points? Are they all the same? They're really not the same. So I've had patients, if you take a 52-year-old man, high-risk disease, persistent PSA after treatment, PSA at 0.4, that patient's going to get treatment. But I've had patients, I think we have one, we're sharing, Stephen, who's 80, 86. I treated him like 15 years ago, and his PSA is 0.4, a doubling time of 2 or 3 years. I think we'll watch him. This whole issue of PSA-targeted therapy, I'm showing you 2 patients here where by identifying the site of disease, we were able to give, I think, really curative definitive treatment. The patient on the left here is a patient of mine who I operated on. Went very well. I think 20 lymph nodes were free of disease. Check2 mutation, hit a PSA of 0.2. We got a PSMA PET, and we identified this presacral lymph node back there, which I think would have been missed by either surgery or radiation. But I couldn't, the fluorophore that you saw presented by Carissa Chu today, I couldn't get compassionate use to use, because these lymph nodes can be difficult to see under white light surgery. He went to Germany, and he had radio-guided surgery in Germany open, and they removed this, and his PSA has been undetectable for the last 5 years. The other patient was a patient who had a PSA relapse. He had no evidence of regional disease, had no evidence of local disease. We did have he had a single bone metastases, which we would have missed if we didn't do the PSMA PET imaging. So these are just two examples where if we could identify the site of disease, we can give more specific, I think, more effective therapy. And we've been watching this for some time now. We've been comparing standard imaging to versus PSMA PET imaging and starting to see now that there can be a statistical benefit to image-guided treatment. So we're starting to see that if you compare PSMA-based imaging to standard bone scans, CT scans, those who got PSMA seem to be at lower risk of what I call tertiary relapse. That means they had treatment, they recurred, and they recurred again. So again, how do my patients make a decision? Again, treatment type, immediate relapse, PSA building time, clear site of disease, those patients get treated. Surveillance is an option. Late relapse, favorable PSA doubling time, no disease identified, advanced age or poor health. Now, someone asked me, what about I had treatment, I relapsed, I got salvage treatment, and my PSA is rising again. What do I do then? Then I really want to identify the site of disease. So in these men, because the alternative is systemic therapy, which can have side effects. So in these men, I really start to watch them very carefully. Because again, as I showed you, a lot of recurrences are in the lymph nodes. And if you could see them, you can get very good targeted radiation. And as we perfect the fluorophore, we may just go in and remove them. So some patients who relapse have what we call oligometastatic disease. That means they don't have widespread disease. They have disease that can be targeted and consolidated with combination therapy, systemic therapy, radiation, surgery. So in summary, prostate cancer is a spectrum of disease at initial diagnosis and recurrence and should be treated as such. PSA cut points which identify cancer recurrence will be updated. We're working with people in Europe, Sweden, and here at UCSF to update these. I'll be sharing these results with Stephen soon. Risk assessment should be refined with new information before treatment. Much will change with better initial treatment. We're talking about that today. Better surgical techniques, better radiation techniques, development of novel therapy. In this next session, you'll hear some amazing things being done here at UCSF and around the world that'll change the way we do things. And again, because we track our data, we have a better understanding of the outcomes of men who get treatment. And all these patients are co-managed with urology, medical, and radiation oncology. We have the most, I think, the best integrated service in the world here at UCSF where people cooperate to get better patient outcomes. Thank you very much.